please join me in welcoming Decca Everest, who is a lead Indigenous engagement partnership cultural safety at the Slocan Site Redevelopment Project. And I know that he wears many, many hats. This is just one of his official job title. So without further ado, I will pass it over to him so he can let us know a little bit more about everything that he's doing. The topic of this session over the next hour is please reset your connection and try again. Co-developing digital inclusion framework, policy, and programming. Welcome very much, Decca. Over to you.
Yes, good afternoon. Before I start, can everyone hear me? So I should not just start running myself before no one can actually hear. So can anyone hear me? Are we good on that side? Just thumbs up. Okay. Yeah. What one word out is a dagat si sanagan na yojats, kanya gehaga kanwa gerdonu, nugawaganya. Danos Gardevo Sosko and Wagita Dota, Aguagon Savada Hostios, Masquian Squamish, Dano Slavative, Tadasua, Dano Aguagon, Nene Coquitlam. So, good afternoon, everyone. My name is Dekat Sanega Everest. I belong to the Ganyakehaga Mohawk people of Gaknawage. I'm a proud member of our Bear clan, specifically from our Susquehanna bloodline. And what I said loosely in well, broken down back into English is I acknowledge that I am a welcome guest on the territories that I work, that my offices are on, which are the unceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh people. And so I'm honored. I do situate myself. I was a welcome guest back in 2010 as part of a initiative, youth initiative that welcomed 350 youth into the territories during the opening ceremonies of the Vancouver Olympics. And since then, I've made my home here and have been welcomed into the Big House and Big House protocols in certain manners. And so I'd like to acknowledge that where I work remains on those territories. And the protocols that I follow adhere to adhere to giving respect to the ancestors, supernatural ones, and hereditary leaders, matriarchs, elected leaders of the nations. And that includes the many supernatural and creatures, big and small, who really take care of and provide those cultural teachings on the land. I'm also very mindful and hold a lot of acknowledgement and respect for being on the traditional territories as I reside within Port Coquitlam. So I'm tuning in to you today from Port Coquitlam, and I recognize that is on the Coquitlam First Nations territories. And so I want to acknowledge that. So a little bit about today is I will be kind of navigating more of a story, sharing a story about the understanding of the rural realities that take place within our work. And let me see if I can switch displays, because that would be wonderful. So, as I mentioned, the understanding the rural realities of communities and specifically my role within PHSA is lead of Indigenous engagement, partnerships, and cultural safety. So a lot of the work that I focus in on is set in and around the Slocan redevelopment, Slocan site redevelopment project. And we're going to kind of take a short ride into what that project is and some of the challenges that are taking place currently in that. And then the third part of this is understanding some of the policy drivers that we've chose to move forward with as part of supporting connection and building a better understanding of how are we supporting patients, Indigenous patients and patients within the urban setting. through this initiative. And I'm going to, so just to give you an idea, let me close all of these. In British Columbia, these are just a couple of stats with regards to reporting out in 2022 around e-health programs and initiatives that do require or leverage the broadband internet delivery for virtual health in and around the province. And so for you to understand, various health centers require nearly half of the health centers existing require upgrades to their technology or broadband standards. Now, when we say broadband standard, that is just the ability to use broadband systems. A lot of the nations and communities, both indigenous and rural communities, dial-up. Majority of the indigenous communities still remain on a dial-up system, and even when they are close to what is considered last mile. So if you picture Highway 16 or a highway going into the regions, most metropolis or most cities, towns in urban or in the rural region are connected to the broadband services. Now, if a nation, and specifically First Nations, if they were to be a mile out or even several hundred feet off of that, the system has never been connected. So there is an absolute disconnect from the accessing broadband services or accessing the fiber lines that have been laid in and throughout British Columbia. So as you can imagine, this has caused a lot of nations to continue focusing on the systems that they have. Most are dial-up systems, some are cellular network, and there are many communities within the regions that still do not have neither. And so cell phone systems don't work. The Nats Valley is a great example where once you go in there, it's kind of like a black hole. As far as trying to get self-service or connectivity. So you can imagine if you or your family were living out in the regions and having to access support services, e-health services, virtual healthcare within that region is next to near impossible. So the total centers in and around the nations are struggling to actually develop new progresses and systems to implement this broadband standard. One of the challenges for us with SLOCAN is our initiative is going to be provincial as well as tackling Yukon territory. So this is kind of a scary feat as far as trying to design a virtual healthcare system in a landscape or geography that doesn't have virtual health technology or capabilities available to them. So just as a quick snapshot, there's a significant, and I'd like to kind of just be mindful that the figures that are being displayed, all right, let me go back one. The figures that are being displayed do not represent Inuit, Métis, or off-reserve, or again, the urban indigenous population. So this is only a snapshot of the First Nations communities on reserve. So you can imagine how the number of telehealth encounters would grow significantly, exponentially, if we began to understand the full impact of. And when we say off reserve, that would essentially mean if a community member who may be from Takla Lake lives off of the actual reserve territory and lives in Prince George, they would not be considered on reserve. They would be off reserve, and therefore some of the health benefits would not actually impact them. And so, again, just taking a quick snapshot of some of the substance use and psychiatry encounters per month within territories. And these are within communities that have access to broadband technology. So again, very, very limited. What we do know is that the technology sector for British Columbia is actually one of our strongest sectors. Its GDP did increase by 2.4% around, which is around $18.3 billion from 2018 to 2019. Our tech sector is growing, and this is an opportunity for us, especially within the health industry, to begin tapping into virtual health as a means to strengthen and engage both our Indigenous communities, rural communities, but also the services that come out of that. It is the tech sector is currently responsible for generating 6.6% of the provincial total's GDP. So it is growing faster than the overall provincial economy, which increased by 2.8%. And the tech sector does outperform the economy as a whole every year in the last decade, with exception of 2015. So one of the interesting parts about this, and especially from an Indigenous lens, is that the economy or the GDP and these opportunities have so much growth potential within Indigenous communities and Indigenous population. And that's because Canadian Indigenous population is actually growing 4 times the national average. And over 60% of BC's rural and remote Indigenous communities still lack that internet connectivity. So bringing, the lack of affordability, high-speed internet connectivity is blocking the economic diversification of remote Indigenous communities and rural communities. And has not only presents major problems, but presents amazing opportunities to strengthen our economy and strengthen the health practices and innovations within our systems. So this is a quick kind of overview of our new Slocan site redevelopment project. This is some of my colleague Tessa Dayton's work, focusing in, so the Slocan site redevelopment project, or Slocan, is a center for youth, youth and families, specifically children living with major health complexities. Right now, if you've visited Sunny Hill, this is a great example of some of the work that is currently being done at Children's Hospital. And over the course of from 2018 to 2028, our project will be expanding. We're currently in completing the business plan, and now in planning and procurement phase, and looking at the rezoning approvals, demolition, and then the development of our permits, which we're actively in today. So one of the big pieces around here is kind of 2 areas. One being the infrastructure, the actual infrastructure of the Slocan site. But what we're going to be focusing on a little bit more is the service provisions, the healthcare coordination of our children and patients within British Columbia as well as Yukon, because the Slocan site in its approach is going to be servicing the Yukon territories as well. And so what we do know from this is our numbers are growing, and the opportunity for Slocan and our approach is really to support families, support children or patients, and their families in around getting the specialized healthcare, the coordination of services and specialists in and around their needs without even having to leave their home or going far from them. So if you can imagine, if we had a child out in Terrace, or a child out in Prince Rupert, or let alone Yukon Territory, who is unable to, or families unable to access specific specific specialists in around chronic behavioral conditions, or there's a significant need to bring their child in for acute care. Often that requires the caretaker and the family to make the trek over to Children's Hospital, and then, as you can imagine, the travel time, the complexity within that itself, is incredibly challenging. We understand that the families, while they do get support and funding for various travel, that it does come at a cost to the individual family themselves. So the design of the new support system, or clinical care plan, is looking at ways that we can create a key worker who's connected to that family, who is kind of the administrator of the care and needs of that family or of that patient, and looking at ways that we can begin incorporating virtual health into that space, so that there is less of a need to travel, less of a need to have visited appointments. And the tricky part of that, again, is for children and families who don't have broadband technology or communications in that matter, even a cell phone call is a challenge for nations or community members who are living in the rural regions. So we are trying to understand some of those. What are the major gaps from a child receiving care? And the first one that we identified is the care coordination. So who are the specialists that child is seeing? Where are they based out of? And what is the technology capabilities that we need that are required beyond just a virtual one-to-one face-to-face engagement? But if there's training needed, if there's much more comprehensive engagement needed, what kind of technology capabilities are going to be required by SLOCAN's project, and how does the gaps within the technology or broadband connectivity kind of impede upon us being able to deliver some of that work? And we know that the availability of those services are kind of scattered throughout BC and Yukon, and the work right now is understanding who and where our specialists are, ensuring that they're then on their respective and have the technology capabilities to service the client or service patients and families in an appropriate way. And so throughout our work now is trying to understand at least from my work, is trying to understand the cultural safety of that, where a child doesn't get referred to a physician or a specialist who may not have that cultural sensitivity or cultural safety in that space, but has the connectivity capabilities. And so we're looking at the certain aspects of the inequities associated to the technology limitations. Another big important piece is our traditional practices. And so how are we supporting children and families who may not be able to get out of the house? A lot of our children have major mobility issues. And so going onto the land, connecting with traditional practices or traditional medicines may be out of the question for some of these families. And so how do we begin looking at technology again as a means to strengthen or be incorporated into those practices, so a child and family could feel a stronger connection to the traditional care plan or the allied integrated health services that we can provide. Some of the proposed activities, and again, the challenge points for us, is the referral intake and assessment process. Now, keep in mind, children and families who are within the regions may not have the full access to the intake or assessment services based on the technology limitations. So we're looking at ways that we can adopt new processes and begin looking at nations, or more specifically, looking at the child, and where that child is based, and you know, from this kind of image, is putting the child at the center, seeing how and where we can develop these kind of 4 areas and build technology services in and around them. So there's far less need for travel unless there's an absolute need or acute care that is needed from there. So one of the significant pieces around technology is, as you can imagine, is the training on for the nations. A lot of communities within the First Nations, a lot of communities within First Nations lack the technology capabilities in their home, and so for Slow Campsite, we have to understand not only introducing technology and introducing broadband partnerships or broadband technology services in that space is just a means to solve all. We have to begin looking at how do we develop our partnerships to begin supporting the training and the implementation of these innovative virtual services. Who's going to be taking the lead on that work? And how do we begin doing or bringing essentially more work to a family or caretaker who is already inundated with the day-to-day engagement and caretaking of their child? So understanding that there is so various kind of hurdles to implementing technology within a community that has never had it. And the tricky part beyond that is, because most urban settings and community and families who are connected to broadband technology, who are connected to the internet, who are connected to the applications and technology services, it's often, I mean, it's a great example, probably a horrible example, but I remember having to, call my mother when I was in high school and asking her to go on to email and send me a document for school. And just that process alone, the frustration behind it, the what do I do now? How do I support? Where do I go? That's simply because there was a lack of digital literacy and technology literacy in the software and applications. So as you can imagine, the health implications, mental health and stress associated to adopting or implementing technology within a region, within a community, or within a family's existing world has a lot of additional considerations that we need to take into moving our patients into a virtual system. Does anyone have questions on this area specifically? Okie dokie. So another area that we're focusing on, again, as I mentioned, is this care coordination. So ensuring with some of our work, and I had mentioned it before, the interprofessional teams, the dyad and triad model. And this really, from an Indigenous lens, is now incorporating traditional knowledge practices into this work, connection to local community, and really bringing technology services through eHealth, an eHealth platform, to the family. So I think one of the most challenging points in there, again, is the geographic location, or the location of that child, and taking kind of a snapshot of who are the interprofessional teams, how are they going to be connected in, and we're looking at doing it a model where they may be close to another acute care center, and building that relationship, or developing a model within the nation, working with the nations directly to understand how can we support this family as a means within the local nation, local community, and the connectivity space there. So the connection, again, that coordinator is really not going to be, or their key worker, if you will, is going to be based for the most part at SLOCAN, the SLOCAN's new site, which is in Greater Vancouver area. So how do we build the relationship between that key worker and the child and patient and caretaker within a community that doesn't have connectivity? Do they fly out and meet with them, or do we look at just phone call conversations or Zoom pieces? And we all know, I mean, we've been through the COVID season, if you will, and we understand the kind of the loss of interpersonal connection, the loss of just human one-to-one engagement, where that does strengthen that relationship. It does strengthen that trust and connectivity. And so as part of this work is, how do we support a family to feel like they can trust their care coordinator, their key worker, beyond just a phone call or never being able to see their face? So some of this virtual technology becomes not only critical, but essential to building a healthy relationship for the family and the key worker to navigate through the healthcare professional teams. So in and around our work, looking at some of the key policy drivers around inclusion, we know that a significant amount of the Indigenous communities and especially within the rural or regions, do have challenges with inclusivity, community consultation, and engagement. And we understand that there is a stronger need, and how we are beginning to look at it with SLOCAN is identifying some of the key policy drivers around the commitments from government to consult with Indigenous communities and develop meaningful engagements. And with SLOCAN, for us, it's the approach that we are taking is going about meeting one-to-one with the families, whether that is, and really basing it on their immediate needs, meeting the families where they are at. So if there's a family who prefers doing one-to-one face-to-face, and they happen to be up in the Yukon Territory, as part of our system and build out is our team is flying over and meeting one-to-one and understanding what are the actual challenges. Do you have broadband technology? We've had experience with various health applications and virtual health services. Oops. One of the biggest considerations for us is that there is a duty to consult. A lot of the approaches that have been taken so far with digital health really does lack Indigenous and rural community representation and voice in the build. There has been incredible amount of work from the First Nations Technology Council and many other organizations who are trying to bring the voice up of communities who are underserved and do not get engaged. Often we design our systems and our processes, especially around virtual health or virtual e-health, our applications from the experience of our own home. And one of the significant considerations, especially if you are on the development or the architecture piece or the policy piece, is to really remove yourself from your home mentally and identify or connect with someone who is in the region who doesn't have self-service. What does that look like for them? It's easy for us to say, oh well, we just we go online, we log in, and we do our work. So therefore, the architecture system should be designed accordingly for a family who might be in the region. going online or connecting to an application may require them to go, 50, 60 kilometers, especially in winter roads on which we are kind of coming into now, just to have access to a virtual health platform. So understanding how we are building these and developing KPIs, our key performance indicators, around specific engagements become critical. Ensuring that we are working with communities in the community who are experiencing some of these kind of connection failures or no connection for that. How does their needs be met? What are some of the key performance indicators that they can identify in the work that we are doing in order for us to design and plan deployment of services within the region or for their child. One of the interesting pieces with the work is to acknowledge that we have Truth and Reconciliation Commission calls to action. We have the United UN Declaration on the Rights of Indigenous People. We also have the Jordan's Principle, which we're navigating, and I think we've come a very long way as far as addressing the needs of on and off reserve individuals or children with medical health needs. The focus now is really the in plain sight report, and understanding that a lot of Indigenous people are left out of the conversation. We are often brought in at the last moment or after the planning stage or the policy or the project has been launched as a means to incorporate or create inclusion for the project, when in all actuality that process needs to start with Indigenous representation at the table from the absolute get-go. What happens as a means of building that project results in a plan or a system that lacks understanding of the intricacies of navigating Indigenous relations or Indigenous populations. And then at a later date, has to be readjusted or reconsidered or redeveloped for that to meet the needs of community that were underserved, and then which ultimately results in additional time being spent on it, longer or push of scheduled programming or scheduled launch, not to mention financial impacts of the project. And as a result of that, Indigenous engagement tends to become seen as problematic. The community by which we're engaging on the project tends to have a bit of frustration with being kind of running behind the 8 ball. So understanding that from the get-go, from the earliest concept, even in the development of that concept, Indigenous representation from the community by which you serve, whether that is urban, rural, or a very specific community, there needs to be engagement right from the get-go, and focusing on not only the healthcare practitioners, but the actual patients and families in that space. Some of the important pieces is that we often we often see Indigenous Indigenous ways of being or Indigenous engagement as an add-on or as an inclusive practice. We also have to consider that both the rural Indigenous realities and just a rural settler realities are very aligned as far as the engagement with consultation. Often we do get opportunities to support the settler experience on there, and as a result, we tend to leave out the indigenous pieces. But there is a kind of a unique space where the rural communities throughout any consultation tend to be left out of the process. And so ensuring that you have partnerships in engaging both respective communities as the development moves forward, or as the planning moves forward, is significant. Acknowledging too that there are cultural education or cultural education information from the non-Indigenous community as well. And that there has to be considerations made from a cultural lens. How do we support rural community members to engage in e-health services? How do they engage in creating what is eligibility? And we're often, kind of ivory tower response to designing and implementing or deploying services. And it's usually a year down the road where these rural communities are catching wind of the design or implementation or deployment without even being brought into the consultation from the get-go. Some of this work can be addressed through Indigenous representation hired on a salary basis, and not just as a consultant of the work, and ensuring that relationship is developed with the communities, with the First Nations communities, and through the respective partnerships, so that it's not just an Indigenous person being at the table to make decisions, but it is a representation of the community or of the nation that is creating that bridge back, acting as that or serving as that liaison to assist the development of various policies or projects or deployment initiatives, so that relationship gets built. Relationship gets built not only on the project or the proposal moving forward, but the actual relationship amongst the healthcare provider, the agency. What we understand right now with PHSA is that there is no formalized relationship with Musqueam, Squamish, and Tsleil-Waututh. An interesting part of that is most healthcare agencies or authorities do not have formalized partnerships with respective nations. So that requires a lot of back and forth with the policy office. And just on our project alone, with the SLOCAN project, we've come to find out that there's 9 other major capital projects that are in the go. And as you can imagine, each capital project with their lead is engaging with the same policy office or the same protocol office of Musqueam, Squamish, and Tsleil-Waututh, asking the same 9 questions over. And so looking at ways to strengthen our approach as capital projects leads, or strengthening our approach as PHSA to understand where we can look to, who we can partner up with, and where we can get the questions answered instead of having to go to the nation directly if the nation has already communicated those. And so some of the work that PHSA is doing now is connecting with creating a best practice with the various health authorities, specifically in Indigenous engagement, to understand where our timelines are, where have the questions been asked around protocol procurement, and begin creating almost a repository of information that can be tapped into, not only as our own PHSA piece, but as in other health authorities to tap into and piggyback onto the learning processes and the journey that that SLOCAN site is navigating into. And again, the major focus remains with regards to Indigenous community engagement is to engage at the local capacity. How are we building in experts within our infrastructure, within our program planning. How are we developing SLOCAN's clinical care plan with the community, with healthcare professionals within the community, so that they are, and both with regards to Musqueam, Squamish, and Tsleil-Waututh, but also within the various nations where our family and children are coming from, to understand that that relationship goes far beyond just a shoulder tap and expectation to provide knowledge, or come in as a contractor, but we're actually looking at ways to employ Indigenous community members as liaisons, as FTEs to support the development of our project, or deployment of e-services or clinical services virtually within their community. And a lot of those, again, what we have done is look at each team, respective team within SLOCAN, identified some of the key policy drivers for TRC, UNDRIP, and Jordan's principle, as well as in plain sight, and began highlighting each policy driver as a means to understand how the work of each team is meeting or addressing the work or the calls to action, and how are we incorporating this reconciliation work through engagement, education, and training into SLOCAN's work on a day-to-day basis. We understand that a lot of this technology, again, it is out of scope for SLOCAN. We cannot develop a satellite system and deploy satellite low orbit satellite systems into each community, but we can work with the nations to understand where we can help support, serve, or bring more focus or create more robust applications for services within their or the service offerings that a lot of nations are currently going for, developing the infrastructure. So if we can identify the needs from a virtual health perspective, that can definitely put a lot of weight into to moving their connectivity initiatives forward. And again, coming back to, we understand that, especially within Indigenous respect, data sovereignty and digital literacy, I'll kind of focus on data sovereignty, is the information that is being shared by community, the data research, when engaging any community, Indigenous community specifically, in and around research. There is various approaches that have to be taken. That the OCAP is a great example, where the knowledge, the information, and the data collected remains at the nation's holding. So how do we develop our work within SLOCAN is, how do we develop engagement and data for virtual health impacts with the community as a means for them to share with PHSA, or for us to develop that process in partnership, so that we can implement the data, work with the nations directly to support that data collection, and again, leave that data to the nations to determine how they want to work with it in the near future. So I know there's quite a bit of information being thrown. A lot of our work in and around SLOCAN is, again, early in development, and we're looking at policy drivers around implementing technology services within Indigenous communities, both BC and Yukon. So does anyone have any questions?
Hi, Decca. Thank you so much for doing that presentation. Like you said, that was a lot of amazing information. I know personally, I've learned so much new learnings from that. There is one question in the Zoom chat right now. I'll read that out to the audience. Suena asks, could the Indigenous people there be trained to be key workers and communicate further with the teams here? This way, the burden on deploying a separate key worker elsewhere would be reduced by having a local connect there who is in direct communication with the child's family. This would create a sense of trust and cooperation between family and the key worker. Also, by this, the technology service there could strengthen by constant communications with the key workers there.
Absolutely. So one of the interesting parts about Slocan redevelopment is, again, moving away from the infrastructure. Some of the pieces that we have to do is design. We're looking at low orbit satellite system services, which is a future technology that will be implemented in the next 3 years to engage with communities. The other aspect on the clinical planning side and services is to understand where the capacity needs are going to be built. So there is going to be a significant amount of hiring in and around the province, and to understand that those key workers may be, rather than deploying them out into community, that they could be trained within community. But as part of that training, again, is it's a duty, as an employer to be able to provide all the technology services capabilities, similar to getting a laptop and getting a phone. Like we have to be able to provide that technology to the employee to do their work effectively. So that's part of our challenges. The hiring process wouldn't be a major piece in comparison to how do we get the technology capabilities ready to go by 2026, so that we can begin doing the hiring within community, but also training those respective individuals on technology that currently isn't available to them.
Thank you for that. To our audience, we have time for one more question, if there's anything. I have a question myself, Decca. So you mentioned that it's important for the internet service providers to also have the education and training to support them as well. I found that idea fantastic, and it's really new to me. Do you know what is happening in that area, whether this is already being done, or if not, then who really in the sector is in the best place to make that happen?
I think, well, and that's a very interesting question in itself. A lot of industries and organizations within the sector often focus in around their work exclusively. So I know the First Nations Technology Council is a great space that is beginning to ask the questions, and working with the various nations and healthcare authorities or health authorities to understand what are the existing gaps. What are the existing gaps within technology services, and the ISPs, internet service providers, kind of putting, not so much the internet service providers are just business to business profit. A lot of that work has to be understood that this is communities that need technology. So if a business cannot support that, or doesn't look favorable to the business as far as profit margins to be accessing or deploying broadband services to the nation, then whose responsibility is it? And again, having an Indigenous community pay for the installation of broadband technologies as part of medical systems, and especially from SLOCAN, is just a very select. We may have one child within that region who needs it. So how do we create more awareness of the medical or e-health services from all aspects of PHSA, all aspects of e-health that can be incorporated into the nation? A lot of times the communities and nations aren't fully aware of the technology capabilities, aren't fully aware of the innovations and applications that could service the communities, whether Indigenous or rural communities. So a lot of that is, again, advocating for the education and understanding of these services and how they need to be implemented into communities. And then kind of putting it to the weight of or the cost, the purse of that deployment and implementation to local, provincial, federal government.
Thank you so much for answering my question. Unfortunately, time is up, and we are so thankful for your generosity for spending a 1 hour special with us today, Decca. For the audience who are just joining us, we are just wrapping up with our noon to 1 p.m. session on Please Reset Your Connection and Try Again, Co-Developing Digital Inclusion Framework, Policy and Programming by Decca Everest. Thank you
Thank
once
you.
again, Decca.